Okay, so students, now we'll be starting with the second part of malaria and babesiosis chapter from Apurba Sastry, and in this we'll be covering the lab diagnosis of malaria, prophylaxis against malaria and babesiosis. So the lab diagnosis: microscopic test, peripheral blood smear gold standard, thick smear more sensitive, thin smear speciation can be done based on the following features: Plasmodium vivax, amoeboid ring form and schizont. Plasmodium falciparum ring forms, multiple ring form, A-seal form, headphone shaped ring forms, banana shaped gametocytes, Plasmodium malariae band forms, Plasmodium ovale, enlarged fimbriated oval RBCs with ring forms. Fluorescence microscopy, Kawamoto's technique, quantitative Buffy coat examination, parasitized RBCs appear as brilliant green dots. Non-microscopic test, antigen detection test, RDTs or ICTs, detects pan-malaria antigen, LDH, aldolase, falciparum specific antigen, HRP second. Culture RPMI 1640 medium, molecular diagnosis, PCR targeting 18S rDNA. Lab diagnosis. The diagnostic test for malaria can be divided into microscopic and non-microscopic tests. See the lab diagnosis box. The peripheral blood smear. Peripheral blood smear study still remains the simple and gold standard confirmatory test for detection of malarial parasites. Specimen. Peripheral blood is the specimen of choice collected from the earlobe or by finger prick in older children and adults from the great toe and in infants. Blood films should be prepared directly from the capillary blood. In case of anticoagulated blood, smears should be made within an hour of collection of the blood. Time of taking blood. Blood should be collected a few hours after the height of the paroxysm of fever and before taking antimalarial drugs. Parasite density is maximum during this period. Frequency. Smears should be examined at least twice daily until parasites are detected. Types of peripheral blood smear. It is of two types, thin and thick smears. Both the smears are made at the same time from capillary blood, either on the same or different slides. At least two thick or two thin smears should be made. For thick smear, a big drop of blood is spread over 1 to 2 cm square area on a clean glass slide. The thickness of the film should be such that it allows newsprint to be read. For thin smear, small drop of blood is taken on a corner of a slide is spread by another slide called spreader at an angle of 45 degree, and then it is lowered to an angle of 30 degree and is pushed gently to the left till the blood is exhausted. The surface of a good thin film is even and uniform, consists of a single layer of RBCs, forms a feathery tail end near the center of the slide, and margins of the film do not touch the sides of the slide. Stains. They are stained with one of the Romanowski stains such as Leishman, Jimsa and Fields, Wrights or JSB Jaswant Singh and Bhattacharya stain. So we can see the thin and thick films of the microscopic analysis. Examination. Both the smears are examined. The thin smear is screened near the feathery tail end. At least 200 to 300 oil immersion fields should be examined before these smears are considered as negative. Advantages. Peripheral smear is simple, rapid and cheap. Thick smear is useful in detecting the parasites. It is 40 times more sensitive than thin smear. Can detect as low as 5 to 10 parasites per microliter of blood. Quantification of parasitemia demonstrating the malarial pigments. Thin smear is useful in speciation of malaria parasites, as we'll see this in the box. Disadvantages: it is labor intensive and requires experienced microscopist. Low sensitivity detection. Limit of thin smear is more than 200 parasites per microliter of blood. Speciation of malarial parasites. The speciation by thin smear is based on the detection of the ring forms schizont gametocyte type of pigment produced by RBC size. RBC size. Parasitized RBC is normal in size and shape for Plasmodium falciparum and malariae, enlarged in size for Plasmodium vivax, whereas Plasmodium ovale RBCs are enlarged with fimbriated margin. Pigments. Malarial pigments in most species are dark brown in color except for Plasmodium vivax, where the pigments are yellowish brown. The level of pigments correlates with severity of the disease. Schizont. Speciation is made based on the number of merozoites present per schizont. Plasmodium vivax schizont is large, 9 to 10 micrometer, completely fills the enlarged RBC and contains 12 to 24 merozoites or schizonts. The Plasmodium malariae and Plasmodium ovale schizont is small, 6 micrometer, almost completely fills or fills 3/4 of the RBC and contains 8 merozoites per schizont. Plasmodium falciparum schizonts are not seen in the peripheral smear. Gametocyte in Plasmodium falciparum, the gametocyte is crescentric or banana shaped and larger than RBC, whereas for other species it is spherical and almost occupies the RBC. Ring forms, it is the most important form that helps in the accurate speciation. It comprises of a vacuole in the central and peripheral thin rim of blue cytoplasm surrounding the red nucleus. Plasmodium vivax rings are 2.5 micrometer in size, occupies one-third of the RBC size. Cytoplasm opposite to the nucleus is thick. Late trophozoites are amoeboid shaped. Plasmodium falciparum rings are 1.5 micrometer in size, smaller than in Plasmodium vivax, occupying 1 by 6 of RBC. Three variants of ring forms may be seen, such as multiple ring forms inside the same RBC, AC Leplic form, ring form attached to RBC membrane, double dot headphone shaped ring form with fragmented nucleus. Plasmodium malaria early trophozoite is similar to that of Plasmodium vivax, but late trophozoite is band shaped, called band forms. Plasmodium ovale ring forms are similar to that of Plasmodium vivax, but present inside oval shaped RBC. Note, in falciparum malaria, only the gametocytes and ring forms are demonstrated in peripheral blood, but not schizons and late trophozoite, as the later stages of erythrocytic cycle occur in deep vessel and not in the peripheral blood. So in this figure, we can see these stages: early trophozoite of Plasmodium vivax, falciparum, malaria and ovale; late trophozoite of Plasmodium vivax, malaria and ovale. Falciparum is not seen in peripheral blood. Schizon of again vivax, malaria and ovale, falciparum not seen in peripheral blood, and the gametocyte of vivax, malaria, ovale are round, while that of falciparum is crescentric shaped. In this thin blood smear, we can see in the first we can see the ring forms. In figure B, we can see the amoeboid form, schizont in C, male gametocyte in D, and female gametocyte in E. Now, in the next figure, thin blood smear showing the falciparum ring forms in A, multiple rings from blue arrow, acyl form from red arrow, and headphone shaped ring form from black arrow. Female gametocyte of Plasmodium falciparum in figure B, male gametocyte in figure C, band form of Plasmodium malariae in D, and ring form of Plasmodium ovale in E. Quantification of parasites. Thick smear is preferred to thin smear for quantification of parasitemia. Previously, the plus system was used, which is simple but far less accurate for establishing parasite density in thick blood films. Now this is obsolete. Currently, the quantification is done by calculating the number of parasites counted compared to the number of white blood cells in the thick smear or number of RBC counted in the thin smear. Quantification by thick smear: number of parasites counted upon number of WBC counted into total WBC count. Quantification is helpful for assessing the severity of infection, monitoring the response to treatment, and detecting the drug resistance of Plasmodium falciparum. Now we see the fluorescence microscopy. Kawamoto technique is a fluorescence staining method for demonstrating malarial parasites. Blood smears are prepared on a slide and then stained with acridine orange and examined under a fluorescence microscope. Nuclear DNA is stained green. Quantitative Buffy coat examination. The quantitative Buffy coat QBC is an advanced microscopic technique for malaria diagnosis. It consists of three basic steps. Blood 60 microliters collected in a capillary tube coated internally with acridine orange. Capillary tube is centrifuged, which causes separation of the components of the blood according to their densities, forming discrete layers such as RBC, WBC, lymphocyte and platelets. Examination of capillary tube at Buffy coat region under ultraviolet UV light source. Interpretation. Acridine orange has been the property of staining the nuclear DNA fluorescent brilliant green. Normally, RBCs don't take up this stain as they are nucleated. However, parasitized RBCs appear as brilliant green dots. WBC also take up this stain. Advantages. QBC is faster. The entire tube can be screened within minutes. More sensitive, at least as good as a thick film, and quantification is possible. So in this figure, in figure A, we can see the QBC capillary tube. In figure B, we see the magnified view of QBC capillary tube containing red blood cell layer, granulocyte, lymphocyte, monocyte and platelets. In figure C, we see the crescent shaped gametocyte of Plasmodium falciparum. And in figure D, we see the ring forms of Plasmodium falciparum seen as fluorescent dots. The disadvantage is it is expensive, less specific and speciation is difficult. Now coming to antigen detection by rapid diagnostic test. Rapid diagnostic tests (RDTs) have revolutionized the diagnosis of malaria. Antigens. Several malarial antigens can be detected. Parasite lactate dehydrogenase (PLDH). It is produced by all Plasmodium species. Currently available test kits can differentiate pan-LDH common to all species and PF-LDH specific to Plasmodium falciparum. Parasite aldolase produced by all Plasmodium species. Histidine-rich protein PHRP. Second, it is produced only by Plasmodium falciparum. Principle. Test kits currently available use a nitrocellulose membrane NCM strip with two parasite detection lines and a control line. Test line 1 coated with capture antibody specific for Plasmodium falciparum, example HRP2 or PFLDH. Test line 2 coated with capture antibodies common to all Plasmodium species, example PAN-LDH or aldolase. Procedure. Drop of blood specimen is added along with a buffer solution to a sample window. Malaria antigens combined with polyclonal malaria antibody labeled with colloidal gold present in the buffer and move along with nitrocellulose membrane to meet the corresponding antibodies at different test lines. Interpretation is based on immobilization of malarial antigen at test line 1 or 2 forming colored bands. If band is formed at only test line 1 indicates Plasmodium falciparum infection. If band is formed only at test line 2 indicates Plasmodium species other than Plasmodium falciparum infection. If bands are formed at both test line 1 and 2 indicates Plasmodium falciparum or mixed infection. Note the band at control line must come to validate the test. If it does not come, test is considered invalid. Control line is coated with antibody against polyclonal malaria antibody present in the buffer. Advantages of rapid diagnostic test. Rapid diagnostic tests are simple to perform, do not need extra equipment or trained microscopist. Sensitivity. Rapid diagnostic tests are more than 90% sensitive at more than 100 parasites per microliter. But the sensitivity is markedly reduced at less than 100 parasites per microliter. Prognosis. PLDH is produced by the viable parasites, hence it is used to monitor the response for treatment. Microscopy is best to assess prognosis. Pregnancy. HRB2 is a reliable marker to diagnose malaria in pregnancy. Severity intensity of the band is directly proportional to the parasitemia and severity of the disease. Disadvantages of the rapid diagnostic test. RDTs have several disadvantages. It cannot differentiate between non-falciparum malaria species. Expensive than peripheral smear. Gametocytes cannot be detected. Low sensitivity. The low limit to detect HRP2 is 40 parasites per microliter and PLDH is 100 parasites per microliter. RDT has not been developed for P. novelci yet. Comparison of the peripheral smear, QBC and RDTs are described in this table. Okay, now in this figure we see the schematic diagram of rapid diagnostic test kit showing negative non-falciparum, pure or mixed infection with Plasmodium falciparum and invalid result of malaria. Alright, in figure B we see the real image of rapid diagnostic test kit. Okay, so now coming to the antibody detection. Antibodies persist even after the clinical cure. Serology does not detect current infection but only measures past exposure. Therefore, Government of India has banned the use of antibody detection tests for malarial diagnosis. Culture. Culture techniques are mainly used for preparation of the malarial antigen, not for diagnosis. Trager and Jensen method using RPMI 1640 medium Roswell Park Memorial Institute has been the most widely used technique for culture of malarial parasite. So in this table we see the comparison of peripheral smear, quantitative Buffy code and rapid diagnostic test. Method cumbersome, easy. Time longer 60 to 120 minutes, faster 50 to 30 minutes, faster 15 to 30 minutes. Sensitivity detection limit 5 parasites per microliter in thick film, 200 parasites per microliter in thin film. Quantitative Buffy code claimed to be more sensitive, at least as good as thick film. Rapid diagnostic test more than 100 parasites per microliter, sensitivity more than 90%, less than 100 parasites per microliter, sensitivity false. Specificity. Gold standard peripheral smear. False positive artifacts may be reported as positive by non-trained technicians in quantitative Buffy code and false positive in RA factor rheumatoid arthritis positive cases in rapid diagnostic test. Speciation, accurate gold standard in peripheral smear, difficult in quantitative Buffy code and detect Plasmodium falciparum but cannot differentiate non-falciparum species in rapid diagnostic test. Cost, inexpensive peripheral smear and inexpensive. Quantitative Buffy code is costly equipment and consumables, and RDTs kits are costly but no extra equipment required, so good for field study. SVN microscopist is required for peripheral smear, not required for quantitative Buffy code. Minimal training is sufficient and not required for rapid diagnostic test as well. The molecular methods. Various molecular tests have recently gained attention for malaria diagnosis. Nested multiplex PCR targeting 18S rDNA has been developed for detection of all 5 human malaria parasites, including Plasmodium novelci. PCR can also be used to detect drug-resistant gene. Real-time PCR useful for quantification and speciation of parasites. Automated system include parasite F digital cytometry and automated microscopy methods have been recently developed for rapid detection of malarial parasites. Non-specific tests. Other non-specific tests include normocytic hemolytic anemia, leukopenia, metabolic acidosis, raised ESR and hypoglycemia. The treatment. Various anti-malarial drugs are depicted in the table, and VP India has given guideline for treatment of Vivax malaria and falciparum malaria described in tables. Severe malaria is a medical emergency, develops quickly over 1 to 2 days and may lead to death. Its diagnostic criteria is given in table. Hence, the treatment should be given promptly. The drug of choice include IV atrimicin derivatives or IV quinine. Anti-malarial drug resistance has emerged as one of the greatest challenges of facing malaria control today. Drug resistance to falciparum malaria. Drug resistance in falciparum malaria is widespread and is described against several anti-malarial drugs. However, there are geographical variations. So, covering the anti-malarial drugs and their activity, quinolones are chloroquine, which are active against asexual RBC stages, quinine against gametocyte except Plasmodium falciparum, mefoquine against asexual RBC stages, and primaquine against liver stages and hypnozoites gametocytes. Artemisinin minus derivative artemisinin, artemether and arteether, asexual RBC stages and gametocytes. Hydroxynaphthoquinones, atowacone, and guanidine derivative proguanil. They are active against asexual RBC stages, liver stages only for Plasmodium falciparum. Okay, now diaminopyrimidines, pyrimethamine asexual stage, liver stages, and sulfonamide, sulfidazine, and sulfadoxine also against RBC stage and liver stage. Tetracycline, and doxycycline against asexual RBC stages. Alright. Now, in this table, we see the treatment of Vivax malaria. Chloroquine 25 mg per kg divided over 3 days, that is 10 mg per kg on day 1 and 2 and 5 mg per kg on day 3. Primaquine 0.5 mg per kg body weight daily for 14 days should be given under supervision, aiming to kill hypnozoites of Plasmodium vivax to prevent relapse. Contraindicated in infants, pregnant women, and individuals with G6PD deficiency. Treatment of falciparum malaria. Northeastern state ACTAL, that is co-formulated tablet of artemether and lumefantrine, total dose 80 mg per 480 mg in adults, given over twice daily for 3 days, plus primaquine 0.7 mg per kg single dose per second day, aiming to kill gametocytes of Plasmodium falciparum. ACTAL is contraindicated in first trimester pregnancy and children less than 5 kg body weight. Other states ACTSP, that is arsenate 4 mg per kg for 3 days, plus sulfadoxine 25 mg per kg, pyrimethamine 1.25 mg per kg, one tablet given on first day, plus primaquine 0.75 mg per kg single dose per second day. In uncomplicated Plasmodium falciparum cases in pregnancy, first trimester quinine salt 10 mg per kg 3 times daily for 7 days. Second or third trimester area specific ACT as given above. In mixed infection, Plasmodium vivax plus falciparum, ACTAL and ACTSP as per geographical area as given above, plus primaquine 0.25 mg per kg for 14 days. World's highest burden. Border areas of Thailand, Cambodia, Myanmar possess the highest risk of resistance to chloroquine and other cases of anti-malarial drugs. Many of the strains of Plasmodium falciparum multiple drug resistant, MDR, defined as resistant to at least more than 3 classes of anti-malarial drugs. Resistant to artemisinin has not been reported from world, although slow clearance phenotypes have been documented. India, chloroquine resistance Plasmodium falciparum has been reported since 1973, first case from Assam. Northeast states show higher proportion of chloroquine resistance in Plasmodium falciparum. The factors that contribute to emergence of resistance are long half-life of drug, mutation in parasite gene, and inadequate and irregular usage of drug. Host immunity. The development of drug resistance can be delayed by combination of drug, that is combining one drug that rapidly reduces parasite biomass with a partner drug that can remove any residual parasite, that is example artemisinin combination therapy ACT. Now in this table we see the severe malaria. It is characterized by more than equal to one of the following phases: impaired consciousness, coma, repeated generalized convulsions, renal failure, serum creatinine more than 3 mg per deciliter, jaundice, serum bilirubin more than 3 mg per deciliter, severe anemia, hemoglobin less than 5 gram per deciliter, pulmonary edema, acute respiratory distress syndrome, hypoglycemia, plasma glucose less than 40 mg per deciliter, metabolic acidosis, circulatory collapse or shock, systolic BP less than 80 mm Hg or less than 50 mm Hg in children, abnormal bleeding and disseminated intravascular coagulation DIC, hemoglobinuria, hyperpyrexia, temperature more than 106 degrees Fahrenheit for 42 degrees Celsius, hyperparasitemia, more than 5% parasitized RBCs. Treatment option available for severe malaria. Drugs are Artesunate 2.5 mg per kg IV given on admission, then at 12 and 24 hours, then once a day. Quinine loading dose of 20 mg per kg at admission, IV fusion in 5% dextrose over a period of 4 hours, followed by maintenance dose of 10 mg per kg 8 hourly. Artemether 3.2 mg per kg IM given on admission, then 1.6 mg per kg body weight per day. Artheter 150 mg daily IM for 3 days in adults only, not recommended for children. Note: in pregnancy, quinine is preferred in first trimester. In severe Plasmodium vivax malaria, treatment is same of Plasmodium falciparum except Primaquine given for first 14 days. For artemisinin derivatives, switch over to oral therapy when the patient becomes stable after 24 hours of parenteral therapy, whichever is later. Drug resistance in vivax malaria. Only sporadic cases of resistance to chloroquine and or primaquine have been reported from some areas of India, Bumrah, Indonesia, and a few others. Mechanism of drug resistance. Chloroquine resistance in Plasmodium falciparum occurs due to mutation in the genes encoding the transport proteins such as PFCRT, Plasmodium falciparum chloroquine resistance transporter, and PFMDR1, Plasmodium falciparum multi-drug resistance gene 1. Such mutation result in impaired transport of chloroquine. Resistance to antifolates such as pyrimethamine is due to the point mutation in DHFR, dihydrofolate reductase gene. Resistance to artemisinin had not been reported yet, however it is observed in experimental animals. Monotherapy with artemisinin is banned in India as it promotes resistance. WHO guideline for assessing degree of resistance. Antimalarial drug resistance detected by in vivo and in vitro methods. In vivo method 2002, the degree of resistance is assessed based on two factors: persistence of clinical manifestation and level of parasitemia following the admission of the antimalarial drug. In vitro test. Various in vitro methods are also available for antimalarial drug susceptibilities testing, such as the WHO in vitro micro test using RPMI 1640 medium, ELISA for measurement of HRP second or PLDH, PCR to detect Plasmodium falciparum specific drug resistance genes. Prophylaxis against malaria. Prophylaxis against malaria. Prophylaxis against malaria includes chemoprophylaxis, vector control strategy, and vaccine prophylaxis. The chemoprophylaxis. Chemoprophylaxis is recommended for travelers, migrant laborers, and military personnel exposed to malaria in highly endemic areas. For short-term chemoprophylaxis less than 6 weeks, doxycycline is recommended at a dose of 100 mg daily. The drug should be started 2 days before travel and continued for 4 weeks and after leaving the malaria endemic area. Long-term chemoprophylaxis more than 6 weeks, mefloquine is recommended at a dose of 5 mg per kg weekly and administered 2 weeks before, during and 4 weeks after leaving the area. Vector control strategy. Vector control is still one of the prime weapons to control malaria in endemic areas. Anti-adult measures: residual spraying the houses with residual insecticides such as dichlorodiaphenyl trichloroethane DDT. Malathion pennythion is highly effective against adult mosquitoes. Space application of pesticides in the form of fog or mist by ultra low volume method of pesticide dispersion. Individual protection done by the reduction of human mosquito contact by using insecticide treated bed nets, repellents, and protective clothing. Anti-larval measures. Larvicide use of mineral oil or Paris green has been extensively used to kill mosquito larvae or pupae. Source reduction to reduce mosquito breeding sites includes environmental sanitation, water management, and improvement of drainage system. Microbiological larvicide, Gambusia affinis fish, and Bacillus thuringiensis bacteria can be used to kill the mosquito larva. Vaccination for malaria. Despite of intense research, till date there is no vaccine licensed for human use. Currently, there are several vaccine trials going on globally in Africa, Asia, and America. Approaches are made for targeting the various stages of malaria cycle. The pre-erythrocytic cycle, targeting sporozoites and liver schizons, aiming at prevent infection, disease, and transmission. Erythrocytic vaccine targeting merozoites, blood schizon. These vaccines help in preventing the disease, thus useful for people living in hyper-endemic areas of malaria. Sexual cycle vaccine targeting gametocyte. They are transmission blocking, do not have prevalent malaria in the individual taking the vaccine, but antibodies are passed to mosquito during the blood meal, block the further transmission of the parasite. The main problems of malaria vaccine include the vaccine candidates are poor inducer of cell-mediated immune response, antigenic mutation and malarial antigens such as PFEMP. A different immune mechanism occur in different stages of malaria life cycle. RTS-SASO1. It is the only vaccine candidate that has successfully completed the phase 3 trial. It is pre-erythrocytic vaccine containing PFCSP, circumsporozoid protein of Plasmodium falciparum fused with hepatitis B surface antigen and a chemical adjuvant AS01. Now we come to babesiosis. Babesiosis is a malaria-like illness seen in cattle and sheep. Babesiosis microti is the most common species, other agents being Babesiosis bovis and Babesiosis divergens. It is similar to malaria parasite in its life cycle and pathogenesis except for the following differences. Heart tick. Ixodes capillaris is the primary vector definitive host of the parasite. There is no liver stage. Sporozoite enter directly into RBCs. Clinical feature differs from falciparum malaria being less severe, low parasitemia and no cerebral involvement. Less severe anemia and no periodicity seen in fever cycle. The disease is more severe in splenectomized and immunocompromised patients. Epidemiology, babesiosis is endemic and temperate area of USA and Europe, not reported from India yet. Diagnosis, peripheral blood smear examination reveals ring forms inside RBCs arranged in a pair or tetrads called Maltese cross forms. It is often confused with multiple ring forms of Plasmodium falciparum but can be differentiated by lack of pigments and lack of concentric gametocytes. Treatment, atovaquone plus azithromycin is given for treatment. So in this figure, we can see the Jimsa stain blood smear showing Maltese cross form. In the schematic diagram in figure A, ring forms in tetrad and peripheral blood smear in figure B. Okay, so this completes our chapter. Now the expected questions. A 54-year-old male from Chhattisgarh presented with fever, chills, rigor with duration of 4 days. The patient developed convulsions prior to admission. He was started on ceftriaxone by private medical practitioner but did not improve on physical examination. Muscle tone and tendon reflexes were reduced. Anemia and splenomegaly were present. The blood sample was collected for peripheral blood smear examination which showed acyl form, multiple ring forms and crescent shaped gametocyte inside RBCs. So obviously this is a case of falciparum malaria. Okay, so what is the etiological agent? We can write briefly about the life cycle, pathogenesis, clinical manifestation and complication, the diagnostic modalities and the treatment we can write. Okay, next question. An 18-year-old female from Udupi, Karnataka presented with high-grade fever which rises every third day and associated with chills and rigor. Her blood sample was subjected to rapid diagnostic tests which reveal bands near PLDH line and control line but no band near the HRP second antigen line. So this denotes that this is a case of vivax malaria. Okay, so we can write the etiological agent, epidemiology and the diagnostic modalities and treatment of the condition. Write short notes on cerebral malaria, this is falciparum malaria, and Plasmodium novelsi we can write. Okay, now the question, which is the infected form of malarial parasite to man? So out of all these, the sporozoite is infected to man. Which is the most infected from malarial parasite to mosquito? So of all these, the hypnozoite stage is the infective stage from mosquito or the gametocyte stage. Okay, now next question, which is true about Plasmodium falciparum? Okay, so it says the high level of parasitemia, yes. Invades erythrocytes of all ages, yes. Erythrocytic schizogamy takes place in capillaries of internal organs, yes. All are correct. Okay, the crescent shaped or banana shaped gametocytes are seen in Plasmodium falciparum. Appearance of fever paroxysm every 72 hours is quatrain periodicity of malaria is seen in the infection with Plasmodium malariae. Okay, babesiosis is transmitted by the bite of tick and Maltese cross forms are seen in babesiosis. Okay, so this completes our chapter of malaria and babesiosis. Like, share, subscribe. Thanks for watching.